First, as I said, we're going to do just a very brief description of what is palliative care. So I'm curious, who in the room has had a formal lecture on palliative care in the past? You can just put your hands up. So most. Okay, great. So hopefully this will be, for the most part, a review, but I just want to make sure we're all sort of on the same page and speaking the same language in regards to what is palliative care. So this is a graph that I like to use, and usually I have a whiteboard and I do a lot of writing, just to quickly describe and understand where palliative care came from, because it's a very new medical specialty. So this is sort of a way of thinking about it, that traditional medicine, so the medicine that you all have been learning and sort of has been what we've been practicing for a long time, the understanding was the goal of medicine was to fix things, right? To cure things, to keep people feeling well. And then over time, people would get sicker and sicker from the point of diagnosis, as you can see on the left, towards, and an easy example would be cancer. And that's one of the more common things that palliative care is involved with. And then at some point, it would sort of be declared that no more treatment could be offered, or this can no longer be cured. And thankfully, this isn't the case anymore. But back 50 years ago, 100 years ago, there are many doctors around the world that then felt, well, the role of traditional medicine, if we can't fix the problem, we aren't really involved anymore. And there were places, the UK specifically, where the patients that they felt they could no longer cure on the cancer ward, they would actually be put off into the corner, and the teams wouldn't even round on them anymore. They wouldn't check in on them because they would say, there's nothing more for me to do. So the doctors felt that their role had sort of stopped in caring for these patients. So what initially happened is someone named Cicely Saunders. Who's heard of Cicely Saunders before? Or the hospice movement? Who's heard the term hospice? Okay, a couple hands. So Cicely Saunders was originally a nurse in the United Kingdom, in England, and she later then became a social worker and then eventually went to medical school and became a doctor. So she saw these patients that were sitting in the corners screaming and uncomfortable but weren't being rounded on anymore, and she said, this isn't appropriate. They still deserve care. There's still things we can do for them, even though we can't cure them anymore. And that's what we called hospice. And that's where hospice came from. So hospice came before palliative care came. But over time, and we're not going to go into all the details, what people started realizing is all the things she did in hospice. So it was expert symptom management, doing a better job communicating with patients and their families about what was happening and what to expect going forward, managing their spiritual suffering and not just their disease. All these things, more and more doctors around the world started realizing, wait, why are we waiting until they're near death or we're not getting treatment anymore to use all of these really helpful parts of medicine? So then people started continuing to use these practices earlier and earlier in the disease process, and that's what we call palliative care. So palliative care is all the skills and parts of responding to suffering that were in hospice, but applied to patients not just at the end of life, but from the moment of diagnosis and through the course of their serious illness. Does that make sense? Any questions about that? So the reason I bring this up for all of you, because it's important for our discussion today about dyspnea and about nausea and vomiting, is it's really important to understand the relationship between traditional medicine, when you're on the wards and you're thinking about your differential diagnosis and you're trying to come up with, why does this patient have chest pain, to understand the relationship between that and palliative care. That when it's done right, these things should always be done together. There's no question of, oh, this patient isn't ready for palliative care yet. Any patient that has a serious illness and is suffering in any way would get the best care if they receive traditional care, which is what all of you are training to do and do a wonderful job of delivering. But palliative care together with that is what will help the patient relieve their suffering and also improve their outcomes and improve their mortality and their ability to respond or improve from the condition that you're trying to treat. So for any patient you're taking care of, when you're preventing things, when you're fixing things, when you're curing things, that's all great and you should absolutely do that. But for any part of suffering that's still left over or refractory suffering, when you then aim to relieve or comfort or support the suffering that's still there in the midst of trying to prevent and fix and cure, that's palliative care. So I have full confidence many of you deliver parts of palliative care every day when you're caring for your patients. but this is a way to think about it, and this is a way to explain. It never makes sense to ask, wait, is this patient under general care, or are we switching to palliative care? Palliative care should be a part of every patient's care plan. And this is one just final example just to clarify this further. And so first of all, we think about patient A. This is just an example. So we have a 43-year-old female with a new diagnosis of stage 2 cervical cancer and worsening pelvic pain. So for this patient, would it be appropriate to say, well, all we're going to worry about is her suffering, so we're just going to treat her with opioids, not admit her to the hospital, and that's it? Would that be appropriate? I can see heads shaking no. So absolutely not, right? Because there's still a ton of traditional medicine that would help this patient quite a bit. We should be trying to get a full diagnosis to stage her cancer to find out, could she have surgery? Would she benefit from chemotherapy? However, when she's in the midst of doing all these things, we're not going to ignore her pain and her worries and her suffering. So she'll still have a little bit of palliative care that could help her, but the majority of what she needs early in her treatment is really traditional medicine, what all of you are learning every day to do well. Now patient B is another example. So now it's the same 43-year-old female, unfortunately 2 years later, and now the cancer is much more advanced, so she has stage 4 cancer, but now she has worsening pelvic pain and new onset dysuria, or pain when she urinates. Now, most of what this patient needs now is palliative care. We cannot cure her cancer. She wouldn't be a candidate for a surgery, but it doesn't mean we stop doing anything that we can prevent or fix. So part of her pain, she has new onset dysuria, she might benefit from antibiotics. Just because she's mostly palliative care doesn't mean we stop doing all the good general medicine stuff that we're learning to do. We treat her dysuria and her potential UTI with antibiotics, but we really pay attention to all the leftover suffering that's still there, because what she'll benefit most from at this point in her disease trajectory is palliative care. So just an example of one patient is about 90% traditional medicine, 10% palliative care. The other patient is 90% palliative care, maybe 10% traditional medicine, but you always need to be thinking about both together at the same time. Does that make sense? We're good so far? All right, perfect. So then the final question is, who should provide palliative care? So there'll be two options, option A or option B. Option A is only specialists in palliative care should deliver palliative care. Who thinks option A is correct? Nobody. Perfect. Everybody should be providing palliative care. It's the same kind of question. Is it only cardiologists that read EKGs, or only pulmonologists or radiologists that look at chest x-rays, or only infectious disease doctors that prescribe antibiotics? Of course, everyone needs to know the basics of all of these modalities, and the same thing is for palliative care. So everyone should be providing palliative care, and that the vast majority of palliative care is not delivered by specialists, it's delivered by generalists like all of you.